Okay, let's go with chapter 39. This is the gastrointestinal system. This is also called the digestive system. This consists of the GI tract and associated organs and glands. This includes the mouth, the esophagus, the stomach, the small and large intestine, the rectum, and the anus. It also includes the liver, the pancreas, and the gallbladder. And here is a picture. Yay! So looking at this picture, what quadrant would you palpate for the spleen? If you said the left upper quadrant, you would be right. My son would say that would be the passenger side upper quadrant, but that is the left upper quadrant for the pancreas. Okay, so the main function of the GI system is to supply nutrients to body cells, and this is accomplished through the processes of ingestion, digestion, and absorption. So ingestion and propulsion of food is controlled by appetite, and that's the appetite center of the hypothalamus, through the mouth, the salivary glands, the pharynx, and the esophagus. So the appetite center is controlled directly and indirectly by hypoglycemia, an empty stomach, decrease in body temperature, input from higher brain centers. The appetite can also be inhibited by the stomach, by distension, by illness, by hyperglycemia, by nausea and vomiting, and by certain drugs. The mouth consists of the lips, the oral bucca, the cavity, and it contains the hard and the soft palates, the teeth, and the tongue. The taste buds are in the tongue, and they also consist of chewing and swallowing, and the teeth are used in mastication or chewing. Salivary glands are the parotid, the submaxillary, and the sublingual, and those produce saliva. The pharynx is divided into the nasopharynx, the oropharynx, and the laryngeal pharynx. The oropharynx is the path for the food between the mouth and the esophagus. The epiglottis is the fibrous lid that closes over the larynx during swallowing, and that prevents aspiration. The esophagus moves the food to the stomach. The upper esophagus, esophageal sphincter, is at the top of the esophagus, and that relaxes during swallowing and allows food to pass through. And then the lower esophageal sphincter provides a barrier at the distal end to prevent reflux of acidic gastric contents into the esophagus. So digestion and absorption. The stomach stores food and mixes it with gastric secretions, and then it empties by small boluses into the small intestine. And only small amounts of water and alcohol and electrolytes and certain drugs are absorbed here. The stomach is divided into three parts, and let me switch slides here. Three parts are the fundus, the body, and the antrum. The lower esophageal sphincter and the pyloric sphincters guard the entrance and the exit. And then there's hydrochloric acid that mixes with the gastric juice, and that makes it acidic. And the acid is a protection against the ingested organisms. And then intrinsic factors promote cobalamin, vitamin B12 absorption into the small intestine. We're going to slide by this picture because that should be a picture of the small intestine. And it's not. All right, so the small intestines are used to digest and absorb. They're made up of the pylorus and the ileocecal valve, the duodenum, the jejunum, and the ileum, and then the villi and the microvilli. The ileocecal valve prevents reflux of the contents of the large intestine. The villi are minute finger-like projections in the mucosal lining that kind of make the food or the contents of the stomach move along in the small intestines. as do the microvilli, but they also, the small intestines contain epithelial cells that produce digestive enzymes too. And all of this increase the surface area of the, that aid in the digestive system. So the physiology of digestion is that saliva helps to lubricate the food. It also helps facilitate swallowing. It also contains amylase, which breaks down starches into maltose. Pepsinogen is converted into pepsin by the acids of the stomach, and pepsin begins to break down protein. So in the small intestines, carbohydrates are broken down into monosaccharides, fats into fatty acids, and proteins into amino acids. So as these secretions are involved in digestions, it includes enzymes from the pancreas, bile from the liver, and enzymes from the small intestines. Absorption is the transfer of the end products of the digestion across the intestinal wall into the circulation, and most of this occurs in the small intestine. Now, elimination is the products of the large intestine, and that's the cecum, the colon, the rectum, and the anus. Absorption of water and electrolytes happens here. This area also forms and stores fecal mass. It secretes mucus, and defecation occurs from the anus in the rectal area through the Valsalva maneuver. And here is the picture of the large intestines. So along with this, we have the liver, the biliary tract, and the pancreas. The liver is the largest internal organ. It sits in the right epigastric region, and it's enclosed in the peritoneum. It's divided by a fibrous capsule, and I think, yes, there's a picture, into the right and the left lobe. The lobule is the functional unit of the liver, and it consists of rows of hepatic cells known as hepatocytes, and those are arranged around the central vein. Let's see, I think that's all we're going to talk about there. And then we're also going to talk about the biliary tract. I'm going to leave the picture up here for a minute because it's going to talk about the gallbladder. And the gallbladder collects bile from the liver. We have the right and the left hepatic ducts. And so the function of the gallbladder is to concentrate and store bile. And then the bile drains into the interlobular bile ducts, and then it unites into the right and the left hepatic duct. The hepatic duct merges with the cystic duct from the gallbladder to form the common bile duct. And the bile is stored in the gallbladder, and then it travels through the common bile duct into the duodenum at the ampulla of Bladder. And that's what that slide was. I wanted you to see the picture for a little bit. Okay, so the biliary tract is related to bilirubin metabolism. And bilirubin consists of water, cholesterol, bile salts, electrolytes, and phospholipids. So bilirubin metabolism is derived from the breakdown of hemoglobin. Unconjugated bilirubin is bound to albumin for transport to the liver. Conjugated bilirubin is soluble and excreted in bile. And then bile is needed for fat emulsification, and that's what the gallbladder stores and squirts out whenever you have a really fatty meal and need just a little bit of help to digest that and get that out of your system. And so here's kind of a picture that gives you an overview of all of that. So you've got the RBC destruction by macrophages, goes into the hemoglobin. It's unconjugated bilirubin, insoluble, so it's attached to albumin, goes into the liver, and it just works its way through. Okay, so now the pancreas. We have the head, the body, and the tail, lobes and lobules, pancreatic ducts, duct that enters the duodenum through the common bile duct, and then the exocrine and endocrine functions. So you know that the pancreatic duct extends along the gland and enters the duodenum through the common bile duct. The functions of the pancreas contribute to digestion through the production and the release of enzymes. Some of those enzymes are through the aisles of Langerhans, the beta cells that secrete insulin and amylin, alpha cells that secrete glycagon, and delta cells that secrete somatostatin, and then F cells that secrete pancreatic polypeptides. So gerontological considerations, when we talk about the gastrointestinal system, xerostoma is a decrease in salivation or saliva production, and it leads to dry mouth and possible dysphagia, which is difficulty in swallowing. It also, decreased appetite is related to a decrease in taste buds and salivary gland secretions. Diminished sense of smell and dental problems are also gerontological issues. Smooth muscle weakness in the esophagus and an incompetent lower esophagus sphincter may lead to delayed emptying in the esophagus. The older adult also has a decrease in hydrochloric acid secretion, which is a reduction in the amount of intrinsic factor that's secreted. The liver size decreases after age 50, but this really doesn't change the liver function any. Then there's obstructive and non-obstructive gallbladder diseases that increase with age. And older adults, especially over the age of 85, are at risk for decreased food intake. And that can be secondary to economic constraints and immobility. But one of the things we watch our elders for are at risk for unintentional weight loss. So just know that one of the gerontological considerations for our elders is unintentional weight loss. Another thing you might want to look out for, since acetaminophen or Tylenol is a drug that is metabolized in the liver, and the FDA has just within the last few years come out with new recommendations for the total amount of acetaminophen a person should have in one day, is to be aware of the amount of acetaminophen or Tylenol that a patient is taking. And then steatorrhea is a condition that is characterized by fatty, frothy, foul-smelling stool. And that can be caused by an obstruction of the common bile duct. So steatorrhea, fatty, frothy, foul-smelling stool caused by an obstruction of the common bile duct. Another thing to mention is that patients with chronic constipation, and constipation can be caused by many different reasons, but usually bowel emptying is a routine, and that usually routinely happens after a meal. Most people should attempt a bowel movement after the morning meal or breakfast. So meals stimulate peristalsis, or the movement of food through the bowel system. So if someone has chronic constipation, they should try having a BM after breakfast. Also exercise helps with BMs, and sometimes a hot beverage. So a cup of coffee with breakfast and a brisk walk around the block, yeah, get you going. Okay, let's talk about assessments of the GI system. As you know, we always do a subjective and an objective assessment. So you know that we always do a health history, and we want to explore any kind of problems that might be related to GI functioning. So we would ask about abdominal pain, nausea, vomiting, diarrhea, constipation, any kind of abdominal distension, jaundice, anemia, heartburn, dyspepsia, changes in appetite, hemoptysis, food intolerances or allergies, excessive gas, bloating, lactose intolerance, things like that. You might talk about their appetite habits, their nutritional appetites. You would ask them, what kinds of food have you had? What did you eat yesterday? Especially if it's a patient with malnutrition, their what did you eat yesterday might be a very important question. You would explore any kind of unexplained weight loss. Look for any kind of history for pre-existing reflux, gastritis, hepatitis, colitis, gallstones, peptic ulcer, anything that's pre-existing. Look for recent history. Also look for past history. Look at the patient's drug use, current and past, and this includes over-the-counter drugs, prescription drugs, herbal drugs, vitamins, nutritional supplements, and then also ask about hospitalization for problems related to GI systems, any kind of abdominal or rectal surgeries. Your physical exam, here's a nice little picture. We talked earlier about the palpating for the pancreas. No, not what it was. The spleen. That's what it was. I told you you would palpate in the left upper quadrant. So here's a picture. Diagram A shows the abdomen divided into right, left, upper, and lower quadrants. Diagram B gives you more of a hashtag or a tic-tac-toe layout of the abdomen if you were going to document this way. So assessment of the objective data goes on for a physical exam. So with an abdominal exam, you need good lighting. You need the patient in a supine position, relaxed with their knees slightly flexed, hopefully an empty bladder. The patient you're going to do a visual inspection and auscultation, percussion, and then palpation. And so here is palpation. And did I skip one? No, I did not. And so in this situation, the practitioner is feeling with hands, with fingertips. I think there's another picture, and that is this one. So the practitioner is also feeling with fingertips. And the next picture is, I want to draw your attention to the upper portion of this. This practitioner is actually palpating for the liver. And she, I guess, is doing this by supporting with the left hand underneath the patient's back at ribs 11 and 12, while the right hand is palpating just below the costal margin. That's important to note because you really should only feel the liver on expiration. You should not feel the liver any other time. If you're feeling or palpating the edge of the liver below the costal margin, 3 centimeters below the costal margin, that's abnormal, and that should be reported to the provider. So the only time you really feel the liver is with a deep breath. When you're auscultating, you would be listening in all 4 quadrants with your stethoscope. You may have to listen for a full 2 minutes before you actually hear bowel sounds. So be aware of that, a full 2 minutes. Some of the diagnostics that we use with Gastrointestinal system, we use radiological studies. We have upper and lower GI. I'm going to go ahead and switch to this picture while I talk about this. And upper GI is where the patient swallows a contrast medium, and it's used to identify disorders such as esophageal strictures, polyps, tumors, hiatal hernia, foreign bodies, and peptic ulcers. But basically, the patient swallows the medium, and then they're scanned with X-rays. This is a picture of a lower GI, and this is done with a barium enema. So again, it detects the same thing, the polyps, tumors, and other lesions. But this is a fairly good diagnostic tool. And then we can also do a virtual colonoscopy, which is a combination of a CT scan or an MRI. It's less invasive than a conventional colonoscopy, but it does require radiation, and the colon still needs to be cleansed prior to the exam. So with this, the patient is going to need to be NPO for 8 to 10 hours prior to the exam. That's with a virtual colonoscopy. That's important for you to know. That's different from an endoscopy, which is direct virtualization of GI structures. Endoscopy or endoscopies, the patient is NPO for greater than 8 to 10 hours. They're going to be NPO overnight. Plus, they're going to go through a major bowel prep for a colonoscopy. We also do EGDs and ERCPs. That's for the upper GI portion of it. But that is done with flexible fiber optics and cameras. And with, we can also do brushings and biopsies with EGDs and colonoscopies, and take tissues for analysis. The major complication with endoscopy is perforation of the structures that are being scoped. Virtual colonoscopy, NPO 8 to 10 hours. There's still a small prep with it, and there's still radiation involved with it. With endoscopy, major colon prep, NPO overnight, more risk with it. It's also the patient is sedated with that. And then the last slide in this is liver biopsy. And there's 2 ways to do this. This is open versus closed. Open is done in surgery, full surgical procedure under anesthesia. I'll go back to the endoscopy for a minute. If a patient is not able to complete the colonoscopy or the bowel prep, that's important to note. That needs to be called to the provider. He or she needs to know that the colonoscopy prep or the bowel prep has not been completed. That may be a showstopper there. So back to the needle biopsy, the open or liver biopsy. Open liver biopsy goes to OR and is done under anesthesia. The needle biopsy, however, can be done in the patient room. It's still done with some sedation, but it's done with a needle. It's a percutaneous procedure. The important thing with a needle biopsy is that patient is going to lay flat in bed for 10 to 14 hours. The liver is a very vascular organ, and it's liable to bleed. So we're going to keep that patient flat in bed for 12 to 14 hours. But the first 2 hours of that patient's going to be put on the right side. And that's going to splint that puncture site. So remember that 12 to 14 hours flat in bed, laying on the right side for the first 2 hours to splint the needle biopsy site and hold pressure on it. We're also going to look at liver function tests, and that's a lab test. That's simply a blood draw for that. And that is it for Chapter 39. So thank you for listening.